usually not a presenter at research forums because I'm not a traditional researcher, but thought we'd take an opportunity to show you a little bit of the work that's going on in the Division of Critical Care and the EC3. We've been open for about 2 years now, and intentionally we're not going to take a deep dive into any one project, but just a surveillance of some of the more grassroots efforts that have been coming up in the last 2 years. We spent a lot of time building the critical infrastructure for clinical care in the last 2 years, and now we're really transitioning into a research platform, and so can kind of go through what's happening. So really want to stay at a kind of a 30,000-foot view. And Dr. Gunnarsson this afternoon will talk a lot more about some of the federally funded trial networks and other bigger projects that are going on within EC3 as well. So we opened just over 2 years ago on February 16th of 2015. We've seen about 5,200 patients pass through EC3 so far. This is EC3 in itself is a bit of a research project, kind of our hypothesis being that we could save ICU admissions with this healthcare delivery model. These slides are from the plenary session we gave at SAM last year, but I updated them with our kind of current numbers. So if you look at, since we've been open until end of this past February, we've been open about 745 days compared to the same time period before. This is just adult patients coming through our ER. Our volume has gone up about 7%. Our admissions have gone up even more, about 8.7%, but despite both increases in visits and admissions, ICU admissions have gone down significantly. If you just look at it as a pure admission rate, that's the difference. It's a relative risk reduction of about 18% and a number needed to treat about 218, meaning that if for every 218 patients who come through our ED, we save 1 ICU admission. And that's about the daily census of the adult emergency department. If you're about 100,000 visit a year ED, you'd save about 470 ICU admissions a year using this type of model, at least in our department. So going through some of the things that are actually happening now or have been happening for a little while, the ERAS score, the Emergency ICU Risk Adjustment Score. This is a Discovery Award project. Kyle Gunnarsson's the PI. It's part of the Joint Institute with Peking University Health Science Center in Beijing. We've been there, they've been here. And this is basically looking at traditional scores like the Davros and SAPS-3 score and how they apply to this unique ED-ICU population. Beijing's had an ED-ICU for over 10 years, has had thousands of patients. And so applying these scores to their patients and our patients in EC3 and seeing how predictive they are of their desired goals of 7 and 30-day mortality, and then using the results of that to develop our own novel ED-ICU score and validate it. So this has been presented by Josh Glazer at SCCM in Hawaii in January, some of the current states. It was also presented at the JI Symposium this past October. The manuscript of the first phase is in final stages of development and getting ready for submission. The design of EC3 itself is a physical structure, a form fitting a function. It was unique in itself. It was the first time, or one of the first times in the institution that this kind of lean design process has been used. That in itself is a work of scholarly work. This was presented at SAM annual meeting last year. Jamal Sosner and I presented this in San Francisco at Healthcare Design Workshop and then at the Healthcare Design National Conference in DC. Work has been recognized. We now are Friday, we'll for the first time present EC3 as a core piece of the curriculum of the 5-day lean healthcare course for the university. And it has been published as a case study in ASAP's Emergency Department Design book in its 2nd edition now. Two-bag method for DKA. I won't steal the thunder of a lot of our residents. Nate Haas, who's presenting shortly on this, but two-bag method for DKA previously only really studied in pediatrics. It's now been a core piece of our clinical care delivery in EC3, very successful. And there's been a lot of work around this already, presented at SCCM in Hawaii in January, SAM's annual meeting last year, this research forum last year, some preliminary work, the MRAM research forum by the residents, and this is a high resident involvement component. They have 2 manuscripts, which are in final stages of submission as well, around the adult delivery of the 2-bag system for DKA. We studied the impact on procedural competency, what happens when you kind of drop this ED-ICU in the middle of a big complex health system, what does it do to procedural training for downstream trainees in the inpatient worlds. Dr. Stoll and Hobson led this with our inpatient colleagues. It's been presented at CORD last year and the Society of Hospital Medicine in San Diego last year. Palliative care, Dr. Harvey leads a lot of this work. We have an end-of-life protocol in EC3, and we've had about 90 patients who have been part of that and actually expired within EC3 as a bit of an expected process. This was presented last year at SAM annual meeting, as well as social media and critical care in Ireland by Dr. Harvey. She has some bigger projects related to this in the works as well. EC3's impact on overdose patients, their disposition, extubation rates, and things of that sort. Dr. Otero is leading that. Also presented at SCCM in Hawaii in January, and the manuscript on this is in progress. Use of non-invasive ventilation in EC3, we use it a lot. We've saved a lot of intubations because of it, changes dispositions frequently. Really proud of this work. It's been led by our nursing colleagues. So our CNS of the department, Renee Havey is the PI, our staff nurses are involved in it. They presented it at SAM last year. They have now started doing scholarly work around their nursing involvement in the development of a unit like this, and I presented it at the CNS annual conference in Atlanta this past March, and again at the Association of Critical Care Nurses in Houston in August. That's scheduled for presentation. PREDICT, which is an acronym for Prognosticating Resuscitation Demands, Integrating Computational Triage. A long name, essentially, Drs. Glazer and myself and a few other people have been working on this, essentially using the electronic medical record to aggregate objective data points, potentially for a corollary for severity of illness. This is in the works. This is what's presented SAM last year and is now one of the featured presentations at the EPIC expert group meeting next month in Wisconsin. Critical care ultrasound, there's lots of projects around this due to the investment of our critical care ultrasound faculty, our fellows, and our track residents. Lots of posters you'll see are relative to this today, but are scheduled to be presented at SAM this year in Orlando, as well as one of our medical students is presenting at Western SAM in Stanford at the end of the month. Cardiac arrest, of course, we have a big involvement in cardiac arrest. This presentation of Dr. Haas and others was accepted for this year in SAM annual meeting. Post-cardiac arrest care segue into critical decisions in emergency medicine was written by several of our physicians, including our residents, will be published in the June edition of Critical Decisions. Our goal-directed CPR algorithm, which is just getting off the ground the last few months, has garnered a lot of both local and national and international attention using objective data points to drive our inter-arrest resuscitations. This has been recognized. Dr. Newmar is presenting at the end of the month in Australia to the Australian Resuscitation Outcomes Consortium on this, and it's gaining quite a bit of attention, and we're looking at now getting data around it and publishing on this as well. So just in conclusion, again, a whirlwind tour just through some of the activity that's started happening and has been happening lately. EC3 is really evolving from a viable clinical healthcare delivery model into an acute critical care research platform, and we're starting to harness the powers of that. It's very conducive to facilitating research projects, again, maybe non-traditional researchers, but across lots of specialties and disciplines, and it's been very collaborative, and is now even branching out in efforts across the country and in the world, as this is a very unique asset that we have, and we've really put a lot of effort into developing it as a research platform now. With that, I'll close and just note that we did also come in as runners-up for the Emergency Care Innovation of the Year Award given out by ACEP and Urgent Matters. We received that at ACEP in Las Vegas last year. And recognized nationally as a very novel, innovative healthcare delivery model. So with that, I will finish. Any questions? Okay. Bill.
Really involved in that, but what's your coordination with the other critical care units in the hospital in terms of, trying to make sure that, nobody's stepping on anybody's toes? And I know that's been a difficult area, but I just, curious how that works.
Yeah, so it's ever evolving. I think we were deliberate, again, about creating a critical care advisory committee for the first 2 years before we ever started, about bringing the medical directors, all the ICUs, to really kind of have an idea of we are taking care of the same patients, and we're trying to deliver the front end of aggressive acute critical care, and how can we help take care of their patients at the early stages with the resources we have. So it's been really collaborative. Bob Heisey and Lena Napolitano and Teresa Jacobs have all kind of continued to come to a lot of our meetings. Going forward, we have mutual research projects with them. Kyle will talk about PEDAL and a few other studies that are going on that are co-PIs across the units. So I think we've become a key piece of the research platform, and we're really the front end of it and a very novel place to deliver it. So it's been very collaborative, and it's still evolving.
I have a question for you. So when you started this with saying you're not used to presenting at a research forum, I don't think in any sentence you would start with I am a researcher. So you've come at this from a different angle, and you're now contributing substantially to scholarly work in the field. So I just wonder kind of what thoughts you have on kind of starting that transition, or thinking about how contributing to data or change from a perspective that started more straight with a clinical vantage point can be, or what that felt like, or thoughts about it.
Yeah, I think, again, I'm not traditionally been in the research kind of domain, but I'm actually becoming more into it almost out of necessity, because as you're doing this work, you realize because again, it's a novel healthcare delivery system, and so you really start to realize in front of you, you see the real change that you're providing, and so you realize the opportunity to disseminate that work and information to other people is valuable. And so the studies almost create themselves out of the work we're doing because it is novel, and you're seeing real-time change. And so it just seems to be a kind of a process as part of what I do otherwise. And it's certainly not just me. There's a massive amount of people that are involved that really are seeing the value, I think, of this really novel delivery model to kind of transition into maybe not even a research career, but lots of scholarly work and research opportunity. And we're just at the very beginning, I think.
Other questions? Yeah, thanks. I think the interest in being able to take the knowledge, and that's part of what what research really is, right? Is being able to take the knowledge you have, and if you find something else that's the best way to do CPR or the best way to deliver care, why would you not want to share that with other people? And that's scholarly work.
Right. That's great.
So, yeah, sorry.